Good morning, everyone, and thank you for joining us today for an update on vaccination for monkeypox. The vaccine for smallpox, called Imvamune, is also effective in preventing monkeypox. And until now, we've had a very limited supply of this product, less than 150 doses. Eligibility for vaccination had been limited to those considered high-risk contacts of confirmed or probable cases. To date, we still have only 2 probable cases in the province. We have confirmed that Newfoundland and Labrador will be receiving an increased supply of Imvamune and can now expand eligibility for the vaccine. We will be launching a focused vaccination campaign for those at highest risk of infection based on what we currently know about monkeypox and its spread in Canada. Monkeypox is caused by a virus and can affect anyone. And I'd like to remind you of what to look for with this virus. People usually develop symptoms 5 to 21 days after being exposed with the monkeypox virus, and symptoms usually occur in 2 stages. In the first stage, or what we call the prodrome, you may experience fever, chills, swollen lymph nodes, headache, muscle pain, joint pain, back pain, or exhaustion. In stage 2 of the illness, a rash typically develops, usually within 1 to 3 days after the fever starts. The rash often starts on the face, arms, and legs, but can affect other parts of the body. The rash progresses from raised red bumps to blisters, and then pustules, and then scabs over. Scabs fall off, leaving new skin underneath. Monkeypox presentation during the current outbreak may not present with the classical symptoms and signs, and an individual could potentially have a rash before the fever or just have 1 or 2 lesions rather than multiple lesions. So we want you to have a high index of suspicion if you're not feeling well. An individual is considered contagious from the start of symptoms until the scabs fall off, revealing new skin. And this usually takes around 2 to 4 weeks. If you start having symptoms of monkeypox, you should isolate at home and immediately contact your healthcare provider or 811 for advice. You can reduce your risk of becoming infected with monkeypox or spreading monkeypox by staying at home if you are sick, avoiding skin-to-skin contact with someone who is infected or may have been exposed, practicing good hand hygiene and respiratory etiquette, including covering your coughs and sneezes or wearing a well-fitted mask, cleaning and disinfecting high-touch surfaces, and practicing safer sex. Monkeypox is spread in a number of ways, including from animals to humans, from person to person, and through contaminated objects. When we see spread from person to person, it is generally through close contacts with sores or blisters. It is also spread through respiratory droplets from coughs and sneezes, and through contaminated beddings and towels. But these are much less commonly seen in our current outbreak in Canada. Monkeypox does not appear to be a sexually transmitted infection based on the evidence we have to date. Unfortunately, the current monkeypox outbreak has disproportionately affected some members of the Two-Spirit, lesbian, gay, bisexual, trans, queer, intersex, and asexual communities. Individuals in the 2S LGBTQIA communities are proactive in protecting their health. Individuals have actively presented for care and testing, which has certainly aided in the early identification of this outbreak. The willingness to come forward for vaccination in other areas of the country has very much helped to control the outbreak. We know individuals in our province want to take the same proactive approach with monkeypox, and I want to thank members of the 2S LGBTQIA communities for your advocacy and willingness to be partners with public health. We value your input. Given the epidemiology of the outbreak in Canada and following the lead of other jurisdictions in the country, starting Monday, August 22nd, we will be offering the Imvamune vaccine to Two-Spirit people, transgender people, and cisgender males who self-identify as belonging to the gay, bisexual, queer, and other people or men who have sex with men communities, and meet at least one of the following criteria: have had sex with 2 or more partners in the last 90 days or are planning to do so in the future, have received a diagnosis of a sexually transmitted infection in the last 6 months, have attended, worked, or volunteered in venues or other locations for sexual contact within the past 90 days, or may be planning to do so in the future, whether inside or outside of the province. The vaccine will also be offered to sexual contacts of those eligibility groups above, as well as to people who engage in or plan to engage in sex work. People in the sex work community have come forward in a proactive way, asking for vaccination against monkeypox to protect themselves, their communities, and their clients. Individuals who engage in sex work are typically vigilant about sexual health, and members of this community often lead the way in safety when it comes to issues of communicable infection. Our regional health authorities will engage with community partners to provide low-barrier access to Imvamune vaccine. If you are eligible for Imvamune, please contact a local public health office in your regional health authority to get more information on how to access the vaccine. You will not be asked how you are eligible. More information will be available on our website today with public health offices. Public health has an important role in disease surveillance, prevention, and immunization, as well as in education and equity. Public health has consulted heavily with our community partners, and we thank all of you for the valuable guidance and feedback we have received. We are concerned that members of the 2S LGBTQIA+ communities are facing undue stigma during this outbreak. Monkeypox should not be associated with any one group or community. It can affect anyone. And while monkeypox has disproportionately affected members of the 2S LGBTQIA+ communities, there are cases in Canada among individuals that are not a part of these communities. So just as with COVID, we remind you to treat everybody with respect, make no assumptions or judgments, and above all, to be kind. And I'll now take questions from the media. Thanks.
You mentioned that this is not a sexually transmitted disease. Can you just expand on, for people who just hear that broad statement, it has been shown that it has disproportionately affected the gay community, but can you just flesh that out a little bit?
Yeah, so if a disease is sexually transmitted, it means that it's actually transmitted in sexual fluids, I guess we'll say, so in semen, in vaginal fluids, and in other ways. So we're not seeing that. There's no evidence to date to suggest that that is the case. We know that sexual contact is generally and often close contact, and so the thinking right now and what the evidence is showing us is that this is really due to close contact, skin-to-skin contact. That's how this is spreading.
In 2 cases, still just confirmed. Is that reassuring? Is it comparative to other jurisdictions? Is it just being very well contained here? Or?
So we have 2 probable cases. They haven't been confirmed, unfortunately, but yeah, I think, we certainly expect to see cases. We're not at all surprised that we've had those cases up to this point, and we do expect that we will see cases just with people, with travel and things like that. It's almost inevitable that we will see it, but we are prepared.
Concerns about stigmatization. Why not expand access to absolutely everybody and kind of take the broadest sense possible and kind of make it as normalized, I guess, as possible, as we've seen during the rollout for COVID vaccines, for example?
The answer to that is just simply supply. The vaccine is not available in a large supply anywhere in the world, and it's not been a vaccine. It's a smallpox vaccine, so it's not been a vaccine that we've had to have provided or supplied in large amounts. Smallpox was eradicated back in the early 80s, I believe. So, we haven't had a need for smallpox vaccine on the same scale as we have COVID. And so we have a quite limited supply of this vaccine. And so obviously we have to be responsible with a limited resource and to make sure that we are offering it to people who are at higher risk and where it's going to have the most impact. And so I would love to be able to do that, absolutely, but that's just not our reality at the moment.
I understand also that the vaccine can be offered after an exposure. So is there some sort of system that the government can set up to prioritize people who are seeking vaccine after exposure? If we understand that might be more important to get their vaccine quicker because their exposure will take root in their body, I guess. It's not a medical term, but is there some system that people who need it because they believe they've been exposed can get it quicker than anyone else?
Yeah, so if we have a confirmed or probable case of monkeypox that we have, then public health, it's what we call a notifiable disease. So if a clinician comes across that, then they have to notify public health that that is indeed the case. If that's the case, then public health will reach out to the person who has the infection, and we'll do contact tracing in the same way that we've done it for anything else that we do, and any other notifiable disease. And then after that contact tracing, then those contacts will be notified by public health and advised of their, well, we'll get a gauge of if they're high risk or not, because some contacts will be quite low risk and don't need the vaccine, but if they're in a high risk category, then they will be advised that they can avail of the vaccine.
How many people do you expect to come forward on Monday?
So we don't really have an answer to that question specifically. I think we've certainly planned for, at the moment, we're expecting to have a few hundred, I think, for sure in the beginning, and that may increase. We've certainly planned for more than that, and our supply will allow us to be able to vaccinate a few thousand, less than 5,000.
How long before so that's been a little over 3 weeks since the first 2 cases were probable cases. So that's 3 weeks now, it's still not confirmed. I mean, how much longer before they will be, and when will we be able to test will the point come when we can test our own?
Yeah, so it's got to do with, so a probable case is somebody who has been identified as being exposed somehow, but we don't have confirmation from the lab. So sometimes that happens because we missed the testing window, for example. So we may not be able to get a positive result. And a confirmed case is somebody who has a positive result from the lab. So a probable case is still treated as a case. It's just that we don't have that laboratory confirmation. It's a clinical diagnosis, so to speak. We do have right now the ability to test for monkeypox in the province. Our lab has developed an assay to be able to do that. It's in the final stages of validation, and so much as we did at the beginning with COVID, we have parallel testing that happens with the National Microbiology Lab as well as our lab here. So that process is ongoing, and that we've had, the sample collection and the ability to test we've had since the beginning. We've been able to send our specimens off to the National Microbiology Lab if need be. So, and our hope is that once this test is fully validated, which it has to be from a quality assurance point of view, then we'll be able to do the testing completely here in province.
Has public health done any projections on monkeypox to look into the future and see how many cases there might be, say, a month from now?
So, I mean, here in the province, we just don't have enough. You need to have data to be able to do modeling, right? And we just don't have enough cases to be able to look at that. So, I mean, it appears that things may be slowing on the national scene, so that's all very good news.
I'm wondering, you spoke about the possibility of respiratory droplets being a vector of transmission. Given that, and given that we know that COVID still circulates, I'm wondering if you could speak to the back-to-school plan and why masks aren't going to be mandatory this year.
I can't speak to exactly what's happening with back to school, obviously. That's not my department. There's no public health emergency right now, so the Chief Medical Officer of Health can only introduce special measures orders when there is a state, a public health emergency. So, we can't bring in a mask mandate in the same way that we did previously. Our recommendation, of course, we know that masks can reduce your risk of either getting COVID and other respiratory illnesses, not just COVID, but flu perhaps as well, and certainly can reduce the risk of spread. We still recommend masks as a way to help reduce your risk, and certainly we've had conversations with the Department of Education about, back to school and what our recommendations would be and our expectations are, and we leave the final policy decisions now up to them.
And how many, sorry, I might have missed this, how many vaccine doses do we have available for the monkeypox vaccine?
So currently right now, I think we have just over, a little over 300 doses in the province at the moment. So we have ordered vaccine. Obviously, because this is in short supply, once it's shipped to us and we have to be able to use it, right? So we're trying, given that we don't really know what the uptake is going to be, we're trying to be as judicious and responsible good stewards of the vaccine as we can, and so we've ordered a small supply that we will get initially, and then but we've been assured that it'll be a quick turnaround. If we need more, we should be able to get more within 48 hours.
Kept in a special freezer like a COVID
Yep.
vaccine did, same
Yeah, so it's stored at minus 80 degrees. So we do have, thankfully, we have those freezers now, so we're able to do that, yeah.
Some comment, I mean, obviously, in the public eye, Memorial University has made their decision on masking, and yet the school system, still education, there, as you said, there's no public health emergency, so no mandate. You know, how should the public rationalize that? They see MUN, a huge community unto its own, now requiring masks, but yet schools a couple of weeks away now from going back, and it's still no, no consistency as far as from post-secondary just to regular schools.
So, Memorial University is its own entity and can make its own decisions, and I think, they've made that based on what they feel they need to do. I wasn't a part of those decisions. I can't really comment on it, and not that I'm saying I should have been. I'm not trying to imply that. It's so I'm sure they've made their decisions based on information that they have gotten. We also have to remember that MUN, they have a lot of really big classrooms with a lot of people in them, which is a little bit different than what we see with school. And, I think while it is it's different and there are different rules, I think we have to realize that, they're making decisions based on the information that they have.
You mentioned the larger classrooms, but of course the concern is a smaller classroom, more confined, easier to contact and spread in a school environment. So
thinking more along terms of a super spreader event, right? So if you're thinking about that, you got a lot larger number of people who may be able to be infected if somebody is there. So, and everybody is making decisions based on not just COVID and its and how it spreads, but also how other respiratory illnesses. They need to look at their human resources and trying to prevent people from, missing work and that sort of thing. So there are lots of things that go into that decision-making process.
Are you confident that when people seek 811 or call 811 or seek the public health office, get their hands on the vaccine, that they're not going to face stigma? They're not going to face any kind of discrimination?
Yeah, so certainly in health, that is a big focus of care, is to provide person-centered care that's non-stigmatizing. And certainly from a clinical practice point of view, that is considered the standard that we provide that kind of care. I can say with confidence that stigma will not be as, stigma is something in public health that we work very hard to not add to or to try to, reduce. So, public health offices will not, will be offering as low barrier, we'll say, access to that vaccine as we can.
People should not be asked why they qualify.
No, we are asking people to self-identify that they are at risk or that they fall into these eligibility categories, and we won't be asking which category or how how they fit there. We certainly, that's not really relevant to us. We just want to know that people, and our experience has been that people are quite good at being able to recognize if they, if they do fit the eligibility criteria. And I think for the most part, people understand the importance of ensuring that that we are reserving that, the vaccine for those who fit those criteria because, it is a limited supply.
Do you have any reason to believe, or is there any thought, and is this any of the reason that we're doing this, that there may be beyond 2 probable cases in the province, or is there any reason to believe?
We don't have evidence to suggest that at this point, but I would not be surprised with the way travel is what it is, and people travel all the time. So, it's quite possible, but we haven't had evidence of that at this point.
Very much preventative.
Oh, absolutely.
In advance.
Yeah.
You also spoke about the sex workers kind of putting their hands up and asking for greater access, and other members from different communities asking for greater access. How big of a difference, how helpful has that been for the department? I mean, can you speak about that? Their actions a little bit more?
Yeah.
What that's provided to you guys?
Yeah, so it's been very helpful for us. We know public health. We're not experts in people like individuals and communities, so necessarily. So I think it's been very very helpful for us to have that input, to have that engagement, feedback, and advice, really, and guidance on how we need to approach this and how we need to ensure that we're providing the best care that we can, the lowest barrier care that we can. And so it's been invaluable to have that feedback for us. It really has. Okay, thanks so much, everyone.